This is lecture 9A, Mobility Disturbances in Pediatrics. It should be pretty short and sweet, hopefully. If you want to review the musculoskeletal system, it's on page 822 to 825 in your book. You should know it from A&P and other classes, however. So fractures, you don't really need to memorize the different kinds of fractures. You can just read over them. Clinical manifestations of fractures, obviously pain, swelling, immobility. They can't move it. They're guarding it. Crepitus means bone on bone. They've got bruising. They can't bear weight. Just for your own knowledge, growing pain is real. It's usually occurs during periods of rapid growth in children. Typically, however, it's not actually bone pain. It's more muscular, especially if they're doing lots of activities during this rapid period of growth. And typically something like Tylenol or Motrin will take care of it. And males obviously grow longer than females, like longer length in time, because their growth plates don't close until later on in life. Fractures, don't need to memorize the different kinds of fractures. However, they can be very mild, like a hairline fracture or something that doesn't even need to be casted or splinted, to very severe where you need to have surgery or be in traction. Most important thing you want to worry about with an open fracture is infection, because the bone is actually exposed outside of the skin, and so it's being exposed to all these germs and everything that it's not usually exposed to. So typically they will get antibiotics even before they go to surgery to fix it. Again, you don't need to know the different kinds of fractures. However, in child abuse, a huge red flag that child abuse has occurred is a spiral fracture in, I would say, probably less than a year, because it's a fracture that is circular and twists around the bone. And so, if you're less than a year, a child is not going to twist that area, and it's not going to be circular. A lot of times when it happens, it's either a parent abusing them or a parent grabbing the child and swinging them or hitting them or something like that. So you should know that a spiral fracture is not common in infants, and it's usually a sign of child abuse. So medical management, obviously you want to get the bone to heal correctly, and children have quick bone healing because of their quick growth in general. And so close reduction, they're not going to be pins and needles. They're going to manipulate it by themselves or put it in a cast. An open reduction does involve surgery, and it can have wires, pins, bones, screws, or plates. And so there's actually hardware going into the bone. You also want to be sure to pay attention to fractures across the growth plate, because they can impact growth later on if they don't heal properly. Casting, so there are two types of casting, pretty much plaster of Paris and fiberglass. You obviously know what a cast is. And plaster of Paris, it does have to remain dry, and it can be pretty heavy, and it does take a while to dry. And fiberglass is water resistant, but it doesn't mold as well to the area that is fractured. So there are pluses and minuses to both types of cast. Application of the cast, obviously, depending on their developmental level, you want to educate them on what's going to happen, what it's going to look like, all of that. They may experience some pain or discomfort because they are immobilizing it, and they may even have to pull on the bone a little bit. So you may want to give them some pain medicine before casting. You want to be sure that the child can hold still as well. So it really depends on the age on whether or not you're going to cast them awake, or we used to do conscious sedations to cast if we didn't think that they could hold still for long enough. Again, that's where plaster of Paris comes into play, where it takes much longer to dry. So nursing care of child with a cast is obviously important. You want to change the position if the cast is wet frequently to ensure the drying of the cast. You definitely want to use your palm of the hand and not the fingers to turn the child. You want to inspect the skin at the edge of the cast for redness, especially if it's all the way up to the groin. You want to make sure it's not getting infected up there. And then this also applies to casts that are all the way up to the groin. So you want to petal, so basically like flower petals, where you're going to literally peel back the edge of the cast so that it's not touching the diaper or groin area. And you can also put some moleskin under there to cover those rough edges, because obviously when you petal them, it's going to be rough on the end. But this protects the cast from urine and stool, and it also protects the skin from sitting in urine and stool if the cast is exposed to it. So that's really important if they are in casts that are all the way up to the groin. And then you obviously want to do neurovascular checks frequently to assess for compartment syndrome. And so something you may want to consider if you're taking care of a child with a cast and pain medicines don't work, you may want to do a neuro check and make sure that the cast isn't too tight, or circulation isn't cut off or something like that if you're concerned about compartment syndrome. And then, things you want to look out for with compartment syndrome, you want to monitor that cap refill, you want to assess the pain level, you want to palpate those peripheral pulses, ask the child if they're experiencing any numbness, look for color changes in their extremity that's casted. I'll never forget one kid that came into the ER who the cast was literally just too tight, or if you cast it early and the extremity continues to swell, this happened to be his arm, but if his arm continued to swell, then the cast is going to end up cutting off that circulation. And so we got him back right away and ended up cutting off that cast, and then he had to be recasted. So you obviously want to assess for those things quite frequently. You want to keep small objects away from children, like M&Ms or anything that might fit in that cast and stay and create skin issues. Like I said, you want to do neurovascular checks 1 to 2 hours during the first 48 hours. Again, looking for compartment syndrome. These are neurovascular checks. I expect you should know how to do neurovascular checks by now, and I also just went over them talking about compartment syndrome. All right, so moving on to traction. This is when the traction exerts pull to maintain a body part in correct alignment for healing. So it completely immobilizes the body part. It helps to realign those fracture fragments. You can see page 855 for the types of traction. You're not going to have to memorize the types of traction. We're just going to go over them and what to expect in nursing considerations. So there are 2 types of traction, skin and skeletal. Pretty self-explanatory. Skin is non-invasive, that achieves an external pull on the body part that's affected. The pull is applied to the skin surface, so it's not internal. and it can be applied intermittently, and adhesive materials or straps were used to attach to the skin. These are examples. Again, you don't have to memorize or know the difference, but we will go over buck traction in detail, so you will have to know that, but the rest of them you won't. Skeletal traction is invasive, and it's exerted by wires or pins that are inserted directly into the bone. Greater force is or can be used, and it is continuous traction. The most serious complication of skeletal traction, obviously, because you have a pin going directly into the bone, is osteomyelitis, which is an infection of the bone. This can also be a surgery complication if they go in and put pins or something into the bone. Typically, they're complaining of localized pain, swelling, tenderness, warmth, unusual odor, and they're definitely going to need IV antibiotics for this. Skeletal traction, again, is just FYI. You don't have to memorize that. So like I said earlier, we're going to talk about Bryant traction, and this is a type of skin traction. It's used strictly in children, and it's really used for children less than 3 years old and that weigh less than 35 pounds. It's used for treatment of a femur fracture or for developmental hip dysplasia. So what it is it's counter traction that is actually applied by the child's weight. So the child's weight is what is putting pressure on that bone to make sure that it's aligned, or that their hips are aligned. And so this is a nursing consideration, and it is important. So basically you should be able to slide a hand under that child's little butt so that the butt is lifted off of the bed. And again, that's because their weight is helping to keep things in line. So you should be assessing this and make sure that your hand can fit under it. If your hand can't fit under it, the traction's not working because their body is resting on the bed, and the traction, there is no traction. So the legs are suspended vertically with the hips flexed at a 90-degree angle from the pulley. So you can imagine it's not fun for these little children. You get bored very easily, and it's just not a fun process. Which is why a lot, as I mentioned in class, most of the time now they are just casted to make sure those hips are in place, because this can be quite traumatizing to the child. An adhesive traction strips are applied to both legs up to the hips. So this is skin traction. But I just want you to know that skeletal traction, you cannot release skeletal traction ever. And so nursing care of child in the traction, you want to do neurovascular checks. They're at risk for skin breakdown, so you want to be sure to check that skin. You want to make sure to, again, check for circulation. Sensory deprivation, like I've already mentioned, they're going to be extremely bored, and so you're going to have to get child life involved and have a lot of games and a lot of movies and just a lot of things to distract them. And this is also pretty important. You want to maintain that those ropes and pulleys hang free, because again, just like if their butt is lying on the bed, if those ropes and pulleys are not hanging free from the poles, then the traction isn't working, and so you're basically doing nothing. So you want to make sure that they're free, and that helps to maintain that upper body alignment. So nursing care, you want to remove the elastic bandages if they're in skin traction at least once a shift to evaluate that circulation and the skin integrity. If they do have elastic bandages with the skeletal traction, you can obviously remove those as well, but you're not going to be able to remove that traction. You're going to do range of motion on the other parts of the body, as we discussed in class. You're not going to do range of motion on the affected limb. Or, you know, if they have both of their legs are involved, then you're going to do range of motion with just their arms. To prevent chest muscle atrophy, you kind of got to get creative, blowing bubbles. If you can teach them how to use incentive spirometry, you can do that. Bubbles probably going to be your better option. Pain control versus muscle spasms. So you can give these children pain medicine, morphine, Percocet, whatever, and it may not work, it may not help, but then you give them a Valium or a Flexeril and it makes it better because their muscles just need to relax. And then obviously you want to use a small fracture pan for them. As I've talked about already, you're going to want to use diversional tactics or activities. And you certainly want to do things that are developmentally appropriate so you can still stimulate that development, because they're going to be in traction for months. And so, you know, a lot can happen in months in child terms. And so you still want to make sure they're developmentally meeting those goals. So pin care may be ordered by the doctor. And this is if they're in skeletal traction. And so typically it's hydrogen peroxide and water. So half strength hydrogen peroxide, half strength water. And you're going to do that once a shift. And certainly with those pins, they go directly into the bone. And so you're going to watch for signs and symptoms of infection. And if you see something that's worrisome, like something that's caked on, you know, blood that's caked on, and they're oozing yellow discharge, you would want to page the doctor and see if they want to come and look at the site or how they would recommend you to clean it. Antibiotic ointment also may be ordered, like bacitracin. You want to do small frequent feedings for them, small portions. You want to increase liquids and high fiber foods because they're going to be on pain medicines. So you want to prevent constipation, and then acidic foods and protein, all to help with bone healing. Moving on to DDH, developmental dysplasia of the hips, which none of you knew what that meant in class. So basically, this is a dislocation of the hip joint at birth. Girls are 4 times more likely to get it as boys. That's just a little interesting tidbit. It's usually unilateral, so it only is going to affect one of their hips, and it's typically the left hip. The cause is unknown. You know, they think there's a hereditary component, but again, it's still unknown. If you want to see a picture of it, you can Google it or look in your book on page 831. Clinical manifestations. So there's going to be limb abduction of the hip, obviously. We talked about this in class as well. There's going to be asymmetry of the gluteal and thigh fat folds. And that's typically, honestly, how it's caught, because in the newborn nursery, they're going to flip that baby over and look at everything, and they're going to have abnormal thigh folds, and so that's a huge red flag. They're going to have a positive Ortolani-Barlow maneuver. I'm not going to expect you to memorize that, but do know that it's positive, and I would recommend just Googling it just to know what it is. Basically, the Barlow is when you move it out and the hip actually pops out. And then the Ortolani is when it pops back in. Oops, What did I miss? Oh, if they're older, they're going to have a limp. All right, so the Pavlik harness, if you want to see a picture of it, I'm pretty sure I pulled a picture of it up in class, but you can go to page 834. This typically occurs in infants up to 6 months, and it prevents those hips from fully extending. And so you want to hold those hips in place, which is what the harness does. And it is skin traction, or called Bryant traction. And then surgery is closed reduction. And it's usually better to take care of it when it's younger, because if you wait until they're older, say around 18 months, it's going to be an open reduction. So their recovery is going to be harder. They're more at risk for infection and all of that. So if they're in a Pavlik harness, it is worn for 24 hours a day for 3 to 4 months. You want to remove only to check for skin breakdown and make sure that it looks okay, and for a bath. And so you want to teach the parents, they're going to go home in this harness. So you do want to teach the parents to be sure to look at that skin 2 to 3 times per day. You know, if they're in the hospital, nurses would do it once a shift, but you want to teach the parents to look at it at home as well. And so you want to support those hips and buttocks when they are out of the harness, which isn't going to be for long. And honestly, the Pavlik harness may or may not work, and they still may need surgery after being in this poor harness for 3 to 4 months. All right, last but not least, we're going to go over scoliosis. You guys should know what that is. It's a lateral curvature of the spine, and it usually develops between 9 and 12 years of age. How they test for it is you go to the doctor, they ask you to remove the shirt, and then they observe the child's back while they're standing up straight, and they're looking to make sure that everything's symmetrical. And then they ask them to bend forward and touch their toes, so like they're diving. And then they're going to notice and see what's going on with their hips and shoulders, and there's a visible hump, and if they can see their spine, if it looks straight or not. If they feel as though there is a curve present, they're going to go for further testing, and that testing is going to show the degree of the curve. There are exercises that they can do to strengthen and stretch those muscles around it. Obviously, that's not going to straighten the bone, but it is going to help to maybe decrease some of that pain and help to make things easier if they end up having surgery. The next option is the brace. It's typically called a Boston brace, and so what this does is it stretches the spine and it relaxes the pressure on the vertebrae. It is worn 23 hours a day, and it's typically done for months, and it keeps that spine in line. My cousin had to wear it, and he was extremely self-conscious about it. So you think about it, you already have, again, you know, I like to look at the whole picture in developmental, and you have a middle school child or a teenager who has to wear this brace for 23 hours a day, and it's under their shirt, and it's not comfortable, and you look different, and so compliance can be an issue, and you want to make sure that the family is supporting the child and all of that. It's not an easy thing to deal with. You know how appearance is important to adolescents. And then if the brace doesn't work, spinal fusion is kind of the last resort. And what that does is it stabilizes the spine, and it arrests that, it stops that progression of the curve. And they're still going to be in a brace or a cast for 6 months after surgery. So they could literally have gone from wearing the brace for a couple months and then it not work to having to wear a brace or a cast for another 6 months. So you're talking, they may be in a brace for a year. And this spinal surgery is obviously extremely, I don't want to say dangerous, but extremely risky anytime you're dealing with the spine or the back. There's just so many things that are going on there that it's just very risky, and you want to use it as a last resort. And so if you have time, which you probably don't, but you can Google spinal fusion surgery, and you can see how many pins and needles and how their spine looks afterwards. It's pretty interesting. And that is all that I have for you guys. Please let me know if you have any questions.